Good afternoon. Can you all hear me without this?
No.
No. Okay, well, that's the answer to that. Then let me see. Is it on?
Just half an ear.
Help me understand how to turn this.
There's a red light.
Is that it? Yeah.
Yeah.
Okay, that's better. Great. Well, once again, good afternoon. It's a pleasure to be with you all. One of the things I want to hasten to say about lunch is that this is not a tax to help pay for health care reform. That we're taking your lunch away from you. So I'm sorry for that, along with the rest of you, I'm sure. It's a delight to be back here today. I don't know, been here, I guess, any number of times over the years talking about issues that we work on, legal aid, where I work. I'm a senior attorney with the Legal Aid Society and have been for, I think, 25 years now here in Cincinnati. So, but I happily get to spend a lot of my work time and life up in Columbus and have over the years working on a variety of policy issues that have to do with programs and services and so forth that affect the people that we serve at Legal Aid, our low-income clientele. So we're kind of constantly in this policy discussion and debate that goes on largely at the state level, but some at the federal level, on important issues that affect our clientele. And as I'm sure you all know or can readily grasp, healthcare is one of the biggest issues that affects people that we see in a wide variety of ways. People, many of them are uninsured and uninsurable because they don't qualify for Medicaid, for example. They're not old enough to qualify for Medicare. They may not be disabled or disabled enough to qualify for Medicaid as a disabled person. And or they may work at a job, a relatively low-paying job, without any benefits, without insurance coverage. So there are lots of ways that our clientele come to us with healthcare needs. And so I say that just by way of introduction to say that we have been deeply involved in this debate, actually for some time, for a number of years, but certainly over the last couple of years since healthcare reform has come back in the national agenda after being dormant for a number of years after the failure to do anything during the Clinton administration. I'm sure looking around the room, I would guess that most of you all have some memory of that. So let me just, with that kind of stuff out of the way, and we're going to do this kind of informally today. What I want to do is just say a very, very few words about the situation that we were facing, kind of set the stage, and then talk about what's happened in Congress. And, you know, I'm sure you all being here today are people who've been following the news about this, so I'm not going to break any radical new ground there, but just to kind of put us in context a little bit about where we are and where this thing is very likely to go. And then I'd like to go to the content of some of this paper I've given you. And let me tell you, this is not even the tip of the iceberg. I mean, there's so much stuff coming out now from so many different sources about what is this about, what does it do, what does it do soon, what does it do down the road. There's been, and I don't think I need to say a whole lot about this, I'm sure you all know this, there's been a very vigorous debate about this topic, both at the state and federal levels. There's been a lot of information, a lot of what I would characterize as misinformation or non-information, bad information, sometimes out of naivete or lack of knowledge, sometimes intentionally, because people with interests have been involved in this debate. Not all of them were eager to see change. You know, some people, the status quo worked for it, not very many, but some it did, and so they were not eager for it to change. But just to make sure you've got, before I start talking about things, there's three different items that I've circulated. One of them, which is stapled together here, is a several-page piece that talks about the implementation timeline with a fair amount of detail about things. It's 6 or 7 pages long. So you should have that. You should have two other pieces that look a lot alike. They've both got colored tops that are similar. One of them is from a group called Community Catalyst, and it's entitled Healthcare Reform Will Secure Coverage and Improve Quality of Care, and that's just front and back. And then the other piece that looks very much like that is a piece from the Ohio Alliance for Retired Persons, and it talks about some things that are of specific importance and an interest to seniors. And I thought that might be something that many of you would find of interest, so we'll touch briefly on that. But so I hope if you don't have those three things, I've got a lot of copies, so if you raise your hand, we'll get you copies. We tried to distribute copies of these to the tables. I think there are a number of them out there. As you all know, and I'll be very brief about this, our healthcare situation in this country is significantly less than optimal. We have somewhere in the vicinity of 47 million. I've seen numbers ranging from 45 to 50, but 47 seems to be a number that people fairly frequently accept as accurate, as the number of Americans who are uninsured, simply have no health insurance coverage, either private or public. They don't have an insurance policy from a company. They're not covered by Medicare or Medicaid or the Veterans Administration, so they're just completely without any source of payment for health care. And that's a big problem. Now, you know, the truth is people do die for lack of coverage, and there are statistics on that. And it's a couple of people a day, I think, in Ohio, maybe 700 or so people in a year. And that's tragic. There are many other people who get coverage, but not in a very efficient or fair or honest way. For example, they don't have coverage, so what do? They go to the emergency room. And it's an inappropriate setting for what they need very often. In other words, they need something that's not really an emergency care, but maybe they need chronic care for a chronic health care condition, or maybe they just need something that's more in the vein of something that a doctor would take care of in their office. But they go to the emergency room, it's very expensive, and it's not the right place for what they need. And in the end, who pays for that? Well, they're not in many cases, in most cases. So the cost of that becomes uncompensated care for the institution, but they in turn increase their prices to other people who have payers in order to recover that money. So we have this thing called cost shifting, and you've heard about that, cost shifting. And healthcare economists have been told not to get in front of that thing, so if I wander over there, somebody yell at me. Healthcare economists have determined that, for example, if you've got a fairly typical family insurance policy that might cost $12,000, $13,000, $14,000 a year, that's the average cost for family coverage, that $1,000 of that premium that you're paying in that year is not to pay for your coverage, it's to pay for coverage for the uninsured. So that's a way that our system is, you know, systems often have a way of figuring out how to solve problems, but in this case, it's not efficient, it's not fair, it's not honest. So it's not a good way to try to provide coverage to people, and it's very erratic. You know, I mean, it just depends on what people do. Some people are way too proud to go to a place and get coverage and not pay for it, or not have it paid for by somebody. And so they don't, they go without. And we know that you know,